like, okay, if you had somebody that had nausea and vomiting that lasted for a long time, what things would be affected? You guys are really doing a great job at saying hypokalemia. But now I'm going to move you a little bit further. What does that mean? What is hypokalemia? If I give you a lab result, what is that? Because you need to be able to identify that what is hypokalemia or what is hyponatremia. So I want you to have that as your reference there quickly at hand. Especially when we start talking about liver disorders, hepatitis and cirrhosis, because your liver does so many things in your body that it's a big one that's going to affect lab values and things that you need to watch. And so I wanted you to have that at hand to help answer some questions. Well, at least I had enough, right? I'm always going to have not enough or too much. So remind me what diverticula are. What does that mean? Yes, outpouching. It's where the wall of the intestine weakens and it starts to have outpouching. And that can happen anywhere along that, from the esophagus down through. And so we call it esophageal diverticula when it's in the esophagus, and then when it gets beyond the stomach and it's into the intestine, we're calling it diverticulum. People have diverticulum. That does not necessarily mean they have diverticulitis. People live with diverticulum all the time. Once they get infected, things get trapped in there, in those pouches, then we lead to diverticulitis. And that is when you'll see people land in the hospital for treatment, because it's a massive infection and it's very painful. And so that's where you'll see patients. Has anybody taken care of somebody that's been in the hospital, med-surg with diverticulitis yet? Yeah, a couple of you have. What kind of treatment did you see them on? Stretch back. Yep. IV fluids, antibiotics, pain medications, and another big thing that we do with diverticulum and diverticulitis is we modify diet for people. So if you have somebody that has diverticula or just diverticular disease, not the infectious piece of it, but just the disease, we want a high fiber diet. We want to promote good digestion and prevent constipation. So high fiber diets, what are things that are high in fiber? It's not meat, that's protein. I'll give you that clue. Fruit, vegetables, whole grains, legumes, beans, those types of things that are high in fiber. And at least 64 ounces of water. At least. Okay, one of the things that can lead to diverticula are obesity. That is a risk factor for the development of diverticular disease. That high fatty diet leads to diverticula. The more obese the person is, the more subcutaneous tissue the person has, the more water they need. So take that 64 ounces and continue to add. If they're overweight or obese, the baseline is 64, they need more than that. So high fiber, lots of water for diverticular disease. Weight loss programs, exercise, all of those things that would help prevent people from getting diverticulitis, that like health promotion for that. Early colonoscopy. If I have somebody that has a high fatty diet and is overweight, what are some other lab work that might coexist with diverticular disease? Not necessarily related to this, but what other things might you see elevated? Their lipid profile, for sure. High cholesterol, high triglycerides, which can lead to cardiovascular disease and all kinds of other wonderful symptoms. So again, I'm saying that because I want you to understand that people don't come in with diverticulum. They have many comorbidities that go along with that. If somebody ends up with diverticulitis, we change that diet. We do bowel rest to begin with. We're usually going to have a period where they may be NPO for a short period of time. We're going to provide them with fluids through an intravenous route, so IV fluids. And then we progress them to a clear liquid, full liquid diet. And when you're progressing them to a clear liquid diet, you want a kind of a low residual clear liquid diet, so things like Jell-O, broth, no pulp, juices with no pulp, low acidity. So orange juice, grapefruit juice would be a good choice for these patients. So then, once they're tolerating that clear liquid, low residue diet, we're going to continue to progress that. And it's almost the exact opposite of what you do normally. You want a low fiber diet, okay? So white bread, peeled potatoes, white crackers, white rice, all those things that are good that you probably shouldn't eat normally. But you can eat those while you're healing. So you're trying to limit the fiber during that healing time. And then once the diverticulitis has been treated, then you're going to move back to that high fiber, high water diet. Does that make sense to everybody? So it depends on whether you're in the active disease process, active inflammation process versus the chronic disease, the acute infection versus the chronic disease. Are you guys with me when I say that? Okay, so if I have somebody that has inflammation and infection in their bowel, if I thought that nobody would come around, I'm just saying, get ready, because I'm tired. Okay. What other things can be affected by that? If your GI tract isn't functioning correctly, what other things can be affected by that? What problems might your patient have? They have acute infection of the GI system. What other things are going to be affected? What lab work would be affected?
Magnesium, kidney.
You could have some electrolyte imbalances. If I have an infectious process, what lab value am I going to? White blood cell count, sure. What does that mean? What would an elevated white blood cell count look like? Greater than 10,000, right? So that's where we hit 5 to 10. Sometimes we see 4.5 to 10. 5 to 10,000 is the normal range for white blood cell count. So if you have somebody that comes in with diverticular disease, diverticulitis, you're going to see that white blood cell count elevated. Make sense? Okay. What else besides an elevated white blood cell count? If somebody is going through an inflammatory process, because it's an inflammatory disease, what other lab work? You're chomping at the bit. What other things can you see elevated?
Sed rate.
Your sed rate. Oh, one more too. What's that? It goes right along with sed rate for inflammatory marker. You want to say it? What?
CRP.
The CRP, the C-reactive protein. Yes. I know what you're getting at though, so just hold that thought for a second. What is a normal sed rate? Zero to 20? So when would I start to get concerned? What kind of 21?
Like 18, 19.
Okay, that's still normal. Okay, so I wouldn't necessarily be concerned at that because this patient has a chronic inflammatory problem. So their sed rate may be chronically a little bit elevated. So they may not be within the normal range regularly. So how would I know when I need to be concerned?
Look at the trends.
Thank you. Look at the trends. I need to go back and look. and you look back, what was that baseline CRP? Because they're not going to be admitted for you when they're in just the chronic stage of the illness. They're going to be admitted when they have that acute infection. But you have access to previous lab work, because chances are they've probably been admitted for diverticulitis before. So it may even be going beyond looking at this hospitalization to look back at previous lab work. So you get a whole picture of what's going on with the patient. Okay? There are labs that you will see that if it's just minutely, like potassium is one. If it is slightly low or slightly high, we start to get concerned. There's other ones like hemoglobin. What's the normal hemoglobin? I think it's like the first one on your list. What do I have on there? 12 to 14? 12 to 15 for females. If it's 11, okay, I'm not too worried about that. If it's 8, I'm worried about that. So you have a little more plate in there. And that makes it hard, and I know that makes it hard because it's just, and you guys learn that as you go, like when do I start to get worried about something versus when do I not? But what I want you to know now at this point is if it is elevated or low, what that looks like, more than just telling me hypokalemia. Because you guys will get that, you guys get there, but now you gotta be able to identify what hypokalemia is.
We didn't get the list.
Oh, I wondered why I had so many extras. You're supposed to just guess.
Yeah.
Did anybody else not get this? Front row, there you go. Everybody's jealous of this row, right? Yeah.
I got it, I just have a question.
Yeah.
So for the study guide, you have on pretty much everything that you asked that we should be like knowing the medications for things.
Okay.
For a lot of these, like the slides that we don't go over meds, should we like specifically be looking in the book or just the ones that
No.
we hit on with medication?
So, because when we talk about hepatitis, we'll get there. I would say for some of these, I'm going to give you more of a class, like IV antibiotics would be a treatment, not necessarily what specific antibiotic.
Some of them have specifics, but if we're not specifically going over them,
Correct.
we don't need to.
Yes, correct. Unless I specifically said that something, then I wouldn't spend a lot of time there.
Perfect.
Okay, what other things? Okay, so you told me that they can have electrolyte imbalances, they can have, whatever else you said. What else of inflammatory markers? What else would be a problem? You have somebody that has problems with their disruption of their gut. What else might that patient be experiencing? Huh?
Malnutrition.
Malnutrition, right. They may be malnourished. What are your lab markers for that? What would you, if you were worried about somebody being malnourished, what would you look at? Albumin and what? Prealbumin. What if somebody is chronically, over time, long-term, having nutritional problems? Which one of those is going to be affected? Albumin. Short-term prealbumin, it's quicker. Long-term chronic issues will be albumin. Michaela started to talk about immature white blood cells, and you are correct. So if I have an elevated white blood cell count and I have an infectious process, that whole inflammatory cascade, one of the things that happens is our body senses that there's an infectious process going on, and it starts to kick out more white blood cells, to try to treat that infection, to try to fight that infection. And your bone marrow can't keep up with that. And so it starts kicking out immature white blood cells, which are neutrophils. And we call that a shift to the left, or vanademia, because we aren't having those mature white blood cells in sufficient numbers to fight that infection. And so that is when we need to get involved as practitioners and add antibiotics because our body can no longer fight that. Okay? Left lower quadrant pain is a hallmark sign of diverticulitis. That's we usually see it in that sigmoid colon. So that left lower quadrant, elevated fever. Why would somebody that has diverticulitis have a fever? Huh? By the infection, right, it's part of that inflammatory process. Why does your body run a fever when you have an infection?
It's trying to fill off the bacteria.
Yeah, you're right, because it's trying to kill off bacteria. Bacteria and viruses, parasites, they all live in a narrow range of normal, and they don't like it when your body's hot. So that's your body's mechanism to help fight that off. So we don't necessarily, if somebody's running a low-grade fever, that's okay. It's okay to let them run a low-grade fever. That helps fight that infection. Nausea, vomiting, gas, cramping, abdominal distension. Sometimes you actually can palpate it and feel a mass there if it's big enough. Be careful. You don't want to rupture a diverticulate that's swollen and inflamed. But blood and stools too, as that lining of that intestine starts to shed. So you get a little bit of blood in the stool. But diet is important. Health promotion is important. It's much easier to prevent diverticula than treat them once they get them. If people have colonoscopies, they can treat diverticula. They can staple them and clamp or band them sometimes through colonoscopies. So they can treat this, but most people will end up with other diverticula if they don't change diet, change lifestyle. Talked about NPO advancing, reintroduce the fiber slowly. Analgesics, pain medication for patients because it hurts. So if they're NPO, it's not going to be oral pain medications that we're going to be giving them. During that acute phase, it's IV. What is our big IV narcotic medications that we give? Dilaudid, morphine, and fentanyl. Dilaudid and morphine, probably more than fentanyl. There might be a PCA. Monitor for perforation. What would it look like if somebody came in with diverticulitis and they perforated a diverticulite?
Would it be the same as the other one where, I don't know what it was, but it was saying hot belly?
Yes, the peritonitis. So, yeah, if I have a ruptured diverticulum, that is going to develop into peritonitis because all of that contents of that valve are just now spreading and filling up my peritoneal cavity. So, what are signs and symptoms of peritonitis? Board-like abdomen, increasing pain, elevating fever, elevating white blood cell count, nausea, vomiting, more severe, uncontrolled, when what we're doing is no longer working. Their blood pressure may originally their blood pressure will start to climb, their heart rate will start to climb, and then if we don't get it under control, they'll start lowering that blood pressure because they'll become septic. So originally high, but then it will start to decrease. During this time of inflammation, I don't want to go in and give somebody enemas and laxatives because I can increase the pressure in the intestinal wall and that can actually lead to rupture of the diverticulum. So I'm bowel rest. I don't want to go and try to clean it out. I don't want to pull more fluid like if I'm giving an enema and increasing the osmotic pressure in the bowels, I'm going to pull fluid in and I'm going to stretch it. I don't want to do that during this time. A lot of times you'll see this, avoid small seed skin, nuts, and corn, like especially during that acute diverticulitis. Like don't give fruit, apples would have a skin on it. They don't want to eat them. Potatoes, things like that, because it can get lodged in those diverticulums. Sometimes seeds, corn, those types of things. We used to hear this a lot more, like people with diverticulosis can't eat strawberries because of the seeds. We don't hear that as much anymore. It's more of a high fiber, high water during the chronic stage and then the low residual, low fiber during got acute phase. They've moved away from telling them that they can and can't eat certain things. Colon cancer. Actually, as far as cancers go, colon cancer is probably one of the better ones to be diagnosed with. We have good treatment options. If it's caught early, most people have a fairly decent outcome. So that's a good thing. We also are very much more aware of colon cancer, and we have had huge pushes for early colonoscopies now. You know, if you're age 50, you need a colonoscopy. If you have a high history of colon cancer in your family, you need it younger. You have a sister, brother, mother, father, they're going to start doing them sometimes in their as early as their 30s. What's the earliest you've done colonoscopies for that?
28.
28. Yeah. The same kind of principles that you would use for heart health, increased exercise, low-fat diets, maintaining a good weight, are all appropriate for colon cancer. High-fiber diets, water, when they say fluids, it's really water they want you to drink. It's not like 64 ounces of coffee. That's not the same thing as 64 ounces of water. You guys know that, right? Even though you live on coffee right now, you're looking at me like, what? It's not the same thing. So you can drink your 64 ounces of coffee, but you need to drink 64 ounces of water too and float away. But it's really water that they want you to drink. The biggest clue to colon cancer is early identification of changing bowel patterns. If you are a person that gets up every morning, drinks your cup of coffee, and poops at 9 a.m., and you all of a sudden stop doing that, and you go 2-3 days, and you have periods of constipation and then periods of diarrhea, or you start to have blood in your stool, and you can't figure out why, you need to get that looked at, because that change in bowel patterns is a clue that there's a problem going on. And when I say, so you guys will go through periods of constipation and diarrhea, normal people were like, I didn't get enough fluid, I was stressed, but it's an unidentifiable cause. I don't know why, or it doesn't get better over time. And I can get it checked out, and they can be, oh, it's inflammatory bowel disease, or, oh, wait, here we go, we have colon cancer. So early identification of those changes in bowel habits. I had a cousin that had changes in bowel habits and actually had blood in his stool and ignored it. And he died at 38 of colon cancer. So it is imperative that you pay attention. You all know what you've had, And you guys ask people, when was your last bowel movement? There's a reason that's legit. It comes down to food a lot of the time. So don't be afraid to ask people that. A colon resection or a colectomy, whether it's a tumor, whether it's an area of the bowel that's got so much diverticulum, or if they keep getting recurrent diverticulitis, we can remove sections of colon. And you have a lot of colon. So you can remove a significant amount of colon and still be okay. They can anastomose, I said that over, they can pull the ends back together, and they can suture that back up. You let the bowel rest and heal, slowly reduce diet, and away they go. And they have fairly good outcomes with that. If they're having to remove large sections of the colon, what do we do instead? Colostomies, ileostomies, right? And sometimes they may give them a colostomy temporarily. Let that area heal, and then reattach the bowel. So a colostomy doesn't always have to be permanent, but it can be. So, you guys know, you remember what a colostomy is? talk to me a little bit about colostomy care. What are the things that you need to do when you have somebody that has a colostomy? Has anybody got to take care of a colostomy clinical? Yes. Yeah. Tell me some things that you know about colostomy care. Increased fiber.
It's really important to look at the site because, like, if it's super red
Yep.
or that's a really bad.
Yeah, assess that stoma, make sure that it's pink, it should be pinkish red, because it shouldn't look like the color of the skin, because your intestine doesn't look like that. But what you don't wanna have is like a dusky or even dark spots on it, because that can be necrosis forming. You know, you need it to be blanchable. When I say blanchable, you guys know what that terminology means? Okay. It should be blanchable. I should be able to see that blood flow return. If I can't see that, I've got a problem. The area around, the skin around it, good care of that. What are some things that we can do for that? Barrier creams, yeah. There is 100 different colostomy bags on the market. Some with the bag attached, some that can come off, all kinds of different things that go on. And a lot of times that wound care nurse will step in and they'll trial different things before they find the one that works for that patient. Because what you don't want is have bad skin breakdown around and it gets really sore because you're going to have to constantly change that, and that's going to be very painful. Or you don't want it to fall off. Keep getting it upset. You don't want it to fall off. Like nobody wants that. What else about colostomies? What else?
Like monitor the output, like monitor any changes in the stool.
Yeah. What's the difference between an ileostomy and a colostomy? What's the difference in the stool you look at?
One's gonna be a lot more liquidy.
Which one's more liquidy and why? Ileostomy, I'm hearing that, but why? Why would an ileostomy have more liquid stool? It's further up. But what happens further down in your bowel? The water gets reabsorbed. Okay, so it hasn't gotten to that point yet. So we still have all that water. So you'll get more watery stool. Versus a colostomy, it's more formed because it's had the chance for your bowel to reabsorb the water. Okay? So talk to me about emptying a colostomy. Everybody's favorite nursing skill ever.
Sometimes you have to burp with that.
Remember to burp the bag. Right. Because they can fill with gas. People that have colostomy still have abdominal gas, and it still has to come out. And if you don't burp it, they can pop and explode and do all kinds of funny things on you. So you are taking care, Amrit, you're taking care of, you made eye contact with me, you shouldn't do that. I see other people like, you're taking care of your patient that has a colostomy, and you're getting ready to get them up. What do you want to do? What did you say? Yeah, make sure the bag's not on anything. Check to make sure it needs emptied. Yeah, you don't want to get them up, and then it's full of Molly, are you having a bad day?
I am.
Not gonna lie. If you have a colostomy or an ileostomy, what is one thing that we do really very commonly in practice? We put this device on patients to ambulate them. Gait belts. Okay. Make sure that you don't wrap that gait belt around and tighten it right on that colostomy bag or that ileostomy. So just be aware all the things that you know you need to do when you get somebody up the phone. Yeah. You will have an instance where you have an accident with a colostomy and you won't do it again. So it happens. It happens. And when people are in the hospital and they're ill, like when you get gastroenteritis or a flare-up and you have diarrhea, they have the same thing happen. And so it may need to be checked more frequently when they're in the hospital for whatever reason. All right. Chemo, radiation are all other also ways. I will not ask you what type of chemo. Gosh, just know. Like I'm not going to specifically. It's a nitrogen ester. I won't do that.
Appreciate that.
Nobody knows that. Okay. Briefly, very, very briefly, going to talk about hemorrhoids and anal fissures. Okay, hemorrhoids are, you guys know what a varicose vein is? That's basically what a hemorrhoid is. So anybody that has increased abdominal pressure is prone to getting hemorrhoids, okay? Pregnant women. Very common side effect of pregnancy is hemorrhoids. Obesity. People that sit for a long period of time, don't get a lot of activity, have an increased risk of getting hemorrhoids. And you can have internal hemorrhoids and you can have external hemorrhoids. So just because somebody has hemorrhoids doesn't mean that you'll be able to see them when you look at the rectal opening with the anus. Sometimes you can. Sometimes you can actually, they will be on the outside and they'll be almost obscuring that anal opening. I love to talk to you, but you're like, really? Yeah. You're looking at me like crazy. And they can be anywhere from uncomfortable to itching and burning to very, very painful. It is not uncommon for people with hemorrhoids to have a little bit of blood in their stool. As that stool passes by those hemorrhoids, it will rub on them and they'll get a little bit of bleeding that comes in that stool. Doesn't mean that they have necessarily a GI bleed. It's an irritation of that hemorrhoid as the stool is passing. So it's very important for them to not have hard stools, like avoid constipation because they won't be able to pass that. Because you can have bigger problems if you would rupture one of those hemorrhoids. It's a varicose vein. It's stretched, it's thin, it's flimsy. And so they can rupture. That's a bigger problem. And then you can get into some more substantial bleeding because of that. Lots and lots of different things that we can do. High fiber diets to prevent the constipation. Do you guys, who are my OB people? Who had OB last semester? What's a sitz bath?
It's like the little salts that they put, the little hose at the bottom.
It's a little pan that sits on the toilet, and then it's a bag of water that kind of, well, you guys know what a bidet is? Does everybody know what a bidet, does anybody not know what a bidet is? What's a bidet, Cabela?
A fancy toilet.
It's a fancy toilet that has a device that will spray water on your butt to clean it off. It's kind of like that. It is an area to keep it clean, and it's usually warm water and helps to soothe it. Another thing that is good for that is when you guys were in labor and delivery, they had the squirt bottles that they would squirt. Same thing. It's like a big bottle that you can just squirt over the area. Because what you're trying to do is avoid wiping that and then further damaging those hemorrhoids or causing more damage to them. So those are definitely things that can happen. Analgesic creams. There's analgesic creams. Over-the-counter Tux pads are one common one. Preparation H is another analgesic cream to help that, to help treat that. And then we get into more serious treatment. If you can't treat them over the counter, or then we want to move into other things. Rubber band ligation simply means they're going to band that hemorrhoid until you cut the blood flow off and it falls off. Okay? And it hurts. Go ahead. Do you have something to add?
They're teeny, teeny, tiny.
Teeny tiny, yeah.
Yeah.
Teeny tiny. Yeah. It's not like you go to Walmart, buy hair ties, and not like that. It's a teeny, teeny, teeny tiny, and they pull it around there. And this is how they used to castrate like pigs and stuff. They would band them. Are you serious? Who grew up in the country? Who grew up in the city? Yeah, that's the thing. That's how they used to castrate animals. They would just wrap a band around them and let it fall off.
Not a rubber band.
Sclerotherapy. This is where they're going to inject something into the hemorrhoid to cause that vein to sclerose, to shrink, to shrivel up. Okay, so again, you're taking needles and injecting them into those,
Is medication in there?
huh?
Is medication?
Yeah, and there's a medication that they use to cause it to sclerose. A hemorrhoidectomy is surgical removal of the hemorrhoids. You guys, this is incredibly painful. Has anybody taken care of somebody that's had a hemorrhoidectomy or know somebody that's had a hemorrhoidectomy?
Oh,
I was in the surgery last semester to watch this.
To watch this?
Mhm.
It's interesting.
I didn't know what I was watching the entire time because I kind of got in late.
Yeah?
And when they pulled the hemorrhoid out, I was like, so what is that? And they said, open your hand. So I opened my hand and they put it in my hand and then they told me what it was and it was disgusting.
How big was it?
It was small.
Yeah?
Like it wasn't too big, but I just know
But it was
that
an internal
painful.
one.
Yeah.
What position did they have your patient in for surgery?
They have their legs like up.
Lithotomy?
Yeah,
Like
lithotomy.
you would do a vaginal surgery. So your legs are up in the air so that they can reach that area, or in that jackknife prone position. They will do that, depending on how deep they are. Throwing in back content. Always pulling it forward. I know you guys, you're like, great, thanks. That's probably gonna be on the test. Okay. But it's painful, and people that have their hemorrhoids removed, they don't want it to lay on their back for like 24 hours. Okay, so you just had somebody either inject something into your anus or do surgery on it. What do you think possibly could be a problem? Yeah, people are gonna have a fear, really fear, of that first valve movement because it hurts. So what would you want to put your patient on? Stool softeners, increase fluids, increase fiber so that they can pass that stool. You do not want them to be constipated when they have that first one. Same rule of thumb for moms that have had vaginal birth. You don't want to, that first bowel movement after giving birth is not a fun one. Okay. The other thing, nitroglycerin can relax the sphincter. So you're not putting it on the actual hemorrhoid itself because we don't want to cause vasodilation. You're putting it on the sphincter because people that have internal hemorrhoids it will cause that anal sphincter to spasm, and that's painful. And so nitroglycerin will relax that sphincter and keep it from spasming. That's not a treatment for the actual hemorrhoid. It's a treatment for the side effect of spasming of that anal sphincter. Okay? We just want to make sure that everybody understands. We give nitro to dilate arteries. That's why it works great with MRIs. An anal fissure is a tear in the anal wall. And you can get, when you have a fissure is a tear. You can have a fissure and then you can have a fistula. There's a difference. A fissure is a tear in the lining. And so there are very, very high risk of infection because of what's there. And so now you have direct access to the bloodstream as all that E. coli passes out of the colon. It's painful. They get blood and stool. That anal sphincter, that internal sphincter spasms. So the topical nitroglycerin works for that. Same thing, topical analgesics, sits back, Botox injections. There you go, Mara. You're the plastics queen. This is up your alley. You can do Botox right into that anal sphincter. And it helps that spasming because it can be painful. But also watch your patient for signs and symptoms of infection. Watch for fever. Watch for increased pain. Watch for elevated white blood cell counts, fatigue, those types of things that would happen if they have this going on until we can heal, let that heal and treat. Because you can't just keep them from having bowel movements. I mean, that's worse. Then you're going to end up with a bowel obstruction. So good care, good hygiene, stool softeners, make sure that they're passing that stool and then watching for that, for that to heal. It's still a mucous membrane, and our mucous membranes heal very, very quickly. You know, a very large, hard stool can cause an anal fissure, passing that. I mean, that can happen. So you just are gonna let it heal, and then you can do some treatment if it's severe and it's not healing on its own. What's the difference between a fissure and a fistula? Do you guys remember back from health assessment?
Isn't a fistula like a hole that leads into like another cavity?
Yeah, absolutely, you're 100% right. So a fistula is gonna either have a tunnel that connects two organs that shouldn't be connected, or it's gonna tunnel into the outside of the skin. So the most common type of anal fistula is an anal vaginal fistula. So women will get fistulas between their colon, the rectal vault, and their vagina, and then stools coming out of places that you don't want it to come out of. Okay? And so most people want that fixed pretty quickly. You can also get fistulas in your anus that tunnel out and be like in the outside, and then you just have stool kind of leaking out of a hole usually on your bottom. And again, you don't, not something you want. Things you didn't know before today, Steve. Okay, so that's an anal fistula. Those need to be surgically repaired. Those need to be surgically repaired. They can lead to abscesses, and that's okay. Well, here's the fistula that tunnels outside. So here's your rectum, and then you just have this area where stool can come. Definitely antibiotics. Pain meds, sits back again, lie flat, post-op for 1 to 2 days, and I send that for hemorrhoidectomy. But the same thing's true here. If you're doing any type of surgery in that area, increase fluid and fiber. Make sense? Make sense? Okay. Pilonidal, I put this on here, I don't even know if it's in your book, so I won't. Pilonidal cyst is a common cyst that comes usually it's right above here in your lower back, kind of right where your crack ends and your back begins. And it is a hair that gets caught in there, and it forms a cyst. And a lot of people are kind of prone to getting them, and they will have to go in and lance them and open them up. And the first time you ever are in the room and they lance a pilonidal cyst, you will never forget it. It is the worst smell in the world. It's terrible. Sometimes they'll do them right in the emergency department. Sometimes they'll take them to surgery. And they're usually going to have to be packed and heal, because you want it to heal from the inside out. So have you had that pleasure?
Mm-hmm.
Yeah.
The doctor had to step out because her eyes were watering and she almost threw up.
Who did?
The doctor.
The doctor that did it had to step. Oh my goodness. That's
It's
what.
not horrible.
It's because it's pussy and it's got bacteria and it's trapped in there and there's usually E. coli in it and it just smells. I mean, it's just bad. But they're really painful for people. They hurt. And so it's actually not an uncommon thing.
She didn't numb it, she still felt it.
So when they lanced it.
Lidocaine in her, but she still felt it.
Yeah. They can be very deep. They can be deep. And when you lance them, usually they're going to drain. So just make sure that if you're going to help with that, they warn you before they do it. You'll want to have a little bit of a heads up.
Is there certain activities that makes it more fun than others? Because my friend
Okay.
from high school got them like a lot, and I didn't know if there was like certain things, or it's just, she had like 3 or 4 of them.
One of the things I've heard physicians tell patients, and honestly, you guys are going to ask me why, and I'm not going to be able to tell you, because I don't know why this would put somebody at higher risk, but like, anybody like get out of the shower and get dressed really quick, but don't dry off really well, they said dry that area really well. And I don't know, I would love for some, I know, that's why I'm like, that didn't make sense to me, and at the time when they told me I guess I was too dumb to ask why, or I was too embarrassed to ask why that would be. So if somebody can tell me why, I will give you extra bonus points on the exam, because I don't know the answer to why that is, but you should keep that area dry and not moist. Do you know why? I just said, oh, okay,
My friend's daughter ended up in Cleveland.
because she kept getting them.
She kept getting them, and Dr. Smith in Fort Wayne could not get it done, and they tried everything. But he actually had her cut her hair
Oh, shave, yeah.
on her head, even, because just any kind of hair, I mean, anything could make her more susceptible. I mean, she had long hair, and I mean, I'm like, I had never heard that before.
Me either, and I want somebody to tell me why cutting the hair on my head would keep me from getting a hair growth on my back.
Because it falls down into your, sometimes you get hair stuck where
Right.
you don't really want it. Not that
It's-
it's-
Everybody's gonna come back next Wednesday with short hair. No, all right. Okay, I don't know, I mean, that's weird. I think probably the more coarse your hair is, probably the more risk you are than if you have fine hair, but that to me, I can rationalize in my head, but the wet and that is weird. That's weird. Okay. I wanna talk about liver here for a second. What are some things that your liver does? Metabolizes medicine. Here's a little picture up on the.
Stores the blood cells.
What else?
Storage
I didn't know, no. I have not touched her.
You have on accident.
Lots of times.
Just a couple.
What else does your liver do, Maddie?
Removes potentially toxic byproducts of certain medications. That's what I already said.
Yeah.
Prevents shortages of nutrients by storing vitamins, minerals, and sugar.
Yep. Keep going.
Oh. Produces those proteins needed by the body.
Okay.
Bile.
Produces
Produces bile.
bile. Produces bile, produces protein, breaks down, and then metabolizes the byproducts of medication.
Regulates blood clotting.
Regulates clotting. This is, your liver is the most important organ to produce the clotting factors that you need in your body. Go ahead.
Helps fight infection.
It can help, it's filters. It can help remove bacteria from the blood. As the blood circles through the liver, it helps remove bacteria. Is there something on there about glycogen?
It says, prevent shortages of nutrients by storing vitamins, minerals, and sugar.
It can store glycogen. It can store sugar for you. So your liver does a lot of things. And whether it is hepatitis, no matter what the cause of the is, whether it's cirrhosis, whether it's liver cancer, all of those things can be affected by that. So hepatitis it's an itis, it's an infection, it's an inflammatory process. Something is going on in your liver and now it's inflamed, okay? Cirrhosis is chronic. It is chronic destruction of liver tissue. Chronic hepatitis or hepatitis infections can lead to cirrhosis. Alcoholism leads to cirrhosis. Your tissue, your cells start to break down, your liver tissue becomes fibrotic, and it can't produce the functions. Liver cancer, same kind of concept. You have a tumor or something in there that is taking up space and not allowing it to do, because remember, cancer by nature is cells that absolutely have no purpose. You know, your cells should have a function, and cancer cells replicate really, really quickly and have zero function. They just take up space. And so they're keeping your body from doing what it should do because they're just sitting there taking up space, not doing anything. So you can have issues with clotting disorders. We won't produce clotting factors. If I don't produce clotting factors, which of my labs will be off? And how will they be off? Your PT, INR, and PTT, for sure. So I'm not producing clotting factors. What will that do to your PT, your INR, and your PTT? It will make it go up. Yes, it's going to increase your risk of bleeding. People with hepatitis and cirrhosis and liver cancer bruise, they bleed, they're bleeding risk. They'll get petechiae, they'll get ecchymosis, they'll get all kinds of things that go on because they can't clot their blood. So this is somebody that if you had this going on, you would not want to go in and be sticking them all over the place because they can't clot, they can't. So avoiding some invasive procedures if you possibly can. You can't produce protein because it is the building blocks to protein. So what lab work would we be looking at? Albumin, pre-albumin, for sure, right? Watching blood sugars because we can't, it stores that sugar and it can't do that. So your body doesn't have ready access to sugar when it needs it. But if you haven't eaten enough, your liver can kick in and give you some added sugar to help stabilize that blood sugar. People with cirrhosis and hepatitis can't do that. And so they'll be hypoglycemic quicker. Does that make sense when I say that to people? Okay. It also is what stores your minerals, especially your fat-soluble minerals like A, D, E, and K. Bile breaks down your fat-soluble vitamins, A, D, E, and K. So if I don't have bile, because your liver is what produces bile, I can't break down A, D, E, and K, which means my body can't use it. It's just going to pass right through. I can eat all the carrots I want. I'm not going to get any of the vitamin A from it. So we would have to then supplement them for sure with those fat-soluble vitamins. We'll talk about that. We'll talk about chronic gallbladder disease too. Because of that, they can't break down those fat-soluble vitamins. So watch those. Watch those. They're not getting that, so we need to figure out how to get them to them. What else did we say? It also breaks down ammonia and bilirubin. So two things that can occur for patients that have hepatitis, like or cirrhosis, they can get what's called hepatic encephalopathy. It's a buildup of ammonia in their blood because their liver can't break it down anymore, and it causes extreme confusion. People that have very, very high ammonia levels are way, way, way confused, like crazy confused. This is not, so if you ever see a question on NCLEX and it says, which patient would you want to put close to the nurse's station, and there's somebody that has a high ammonia level, that's the one you want close. You don't want them down the hall and around the corner because they will be on the floor. And you're usually giving them a lovely medication called lactulose, which does the same thing that K-oxalate does for potassium. It binds to the ammonia and they get rid of it in their GI tract, so it causes them to have extreme diarrhea. So now you have your patient that's crawling out of the bed and crazy, having diarrhea everywhere. And so, yeah, you want this patient close. You don't want a surprise when you have to get them off the floor in their pile of poop. So, make a good decision. Know what your elevated level. What's your normal ammonia level? So there would be a question on the test that would say, which one would you be concerned about? 50 to 60? 15 to 60. 15 to 60. So if you have an ammonia level of 120, that's a big deal. That's high, and I need to worry about that. If I have a ammonia level of 62, okay, they probably have chronic liver disease. They probably have cirrhosis. It's probably going to be a little bit elevated. It's in the miscellaneous.
Do you want, underneath the liver functions, you have 10 to 10. Okay. Is it really 10 to everything? Because everything's different.
I know. Yeah. Let me think about that. Let me think about what I really want that normal range to be. I'd rather see the 15 to 60 because it's a narrow range.
Right.
The 10 to 80 is pretty wide.
So for test purposes, though, what do you want?
Do they have ammonia in this? 10 to 80. Oh, 60. No, I want it to be 15 to 60. Okay. Moving on. Types of hepatitis. There's different types of hepatitis. There are A, B, C, D, and E. We vaccinate against which ones? A and B. We vaccinate against A and B. Everybody gets hepatitis B. You get it as a baby. Some of you probably given hepatitis B vaccine. It's childhood immunization. How do you give it? Did you give it no B? No. Some people get to give it no B because they give it that first dose before they leave the hospital. Hepatitis A is sometimes recommended for people that work as contamination, fecal route, crowded areas, hepatitis B, healthcare, blood, and body fluids. Hepatitis C, most common, is IV drug use or post-transfusion hepatitis. This is not a huge risk anymore because we test blood with so much scrutiny that we don't see that transmission, but in theory, it could still happen. Hepatitis D, you can only get hepatitis B. You can only get hepatitis D if you have hepatitis B. They go hand in hand. And hepatitis E is a waterborne virus. So when you guys are out on vacation and you think about sitting in that hot tub that lots of other people have sat in, make sure it's hot so it can kill stuff off. But contaminated water, it's a waterborne virus. So, yeah. I like this slide because it gives you cues. Hepatitis with a vowel comes from the bowel. I love these things. So, A and E, and you can have a vaccine against it. No, for A, not E. Hepatitis B is body fluids. Yes, there's a vaccine against it. Hepatitis C is circulation, transmission from blood and body, no vaccine. And then hepatitis B is your super infection with hepatitis B. So people get hepatitis B, and then they can actually develop hepatitis D as a super infection on top of it. People that have hepatitis, nausea, vomiting, anorexia, they will get, their abdomens will feel really full. Your liver, think about where your liver sits in your body. Okay, this is big, so listen to me for just a second. As your blood is circling back to your heart, so it's coming back to your heart, it circles through your liver before it comes back to your heart. Because, remember, it filters bacteria out of your blood. What you don't want to do is have bacteria in your heart, and then you get bad things happen. So right before it comes back in, it's going to circle through the liver, and then it's going to come up and dump into that right atrium again. People that have liver disease, whether it's hepatitis or whether it's cirrhosis, the blood flow through the liver, so the vessels that are actually inside the liver become very damaged. Just like it's damaging the tissue of the liver, it's damaging those vessels. And so then as the blood comes back, it gets backed up because it can't get through those really rigid, tortuous, damaged veins that are in the liver. And we get what's called portal hypertension. So that portal vein, you're backing up in there and it gets really, really high blood pressure in that area. And so that portal vein is what's pulling blood back from your GI tract. So you'll get things like esophageal varices as those blood vessels around that esophagus get high pressure. You get intestinal veins that they'll be protruding and you can actually see them because of all of that pressure. And then you can start damaging those organs as that blood can't get through and it starts to back up. Secondary, it's like a renal hepatic disorder or secondary injury because your kidneys, that backflows and then they get high blood pressure in their kidneys and it damages their kidneys. So it's because of how the blood flows back to the heart that causes this problem, this portal hypertension in that portal vein, that then all of these other things can happen. This is your slide that had all the different liver functions on it. We talked about anorexia, nausea, vomiting. They're tired, they have low energy, they'll run low-grade fevers because it is an inflammation. They have like flu-like symptoms sometimes, diarrhea or constipation. Skin rashes. Why would somebody that has liver damage get skin rashes? What's one of the things that I just said that it does? Huh? Filters bacteria, right. And so they can get rashes, they can get secondary infections, they will get jaundice because your liver will break down bilirubin and it cannot. Dark urine, as the metabolites don't get broken down, they can do kidney damage. Pruritus, you'll get like crystallization on your skin because your body's not breaking down those byproducts, and then your skin gets really itchy. It's not a good thing to have. It's not good. Hepatitis is not good. We can treat it with lots of different drugs. Mostly we're giving antiretrovirals or interferon to treat hepatitis, and it's long-term. And a lot of antiretrovirals, I can't get that out, have some pretty serious side effects. And so the treatment of hepatitis can be kind of rough. And people that have chronic hepatitis are going to have to be on treatment for the rest of their lives. Good hand washing. Treat this like somebody that uses the same principles as somebody that would be immunocompromised. You want to avoid infection. Don't share personal hygiene products. Don't share toothbrushes and things like that. You're trying to prevent them from getting an infection. Eating utensils. Remember that protein is the building blocks to everything that's in your body, and so they can't build a response. Vaccinations for high-risk people. Avoid alcohol. Alcohol is going to further damage the liver. I mean, cirrhosis, the number one reason that people get cirrhosis is because of alcoholism. So if you already have a damaged liver, you really don't want to damage it even further. Why acetaminophen? Why would you avoid acetaminophen? Tylenol.
It really helps.
It damages your liver.
High levels of Tylenol, remember 4,000 milligrams is your limit, and they can't even take that because their liver can't break it down. So any medication that is hepatotoxic, if you have somebody that's got hepatitis or cirrhosis, you gotta be very, very, very careful giving them those medications. And the benefit of the medication has to outweigh the risk to the patient. And there's other we wouldn't give Tylenol because there's other medications on the market that can do what Tylenol does. You can use other medications. What other medications do we have that we give fairly frequently that have Tylenol in them?
Cold.
Can be cold medicine, like over-the-counter combination. What else? Not hydrocodone, Lortab, Norco. They're all, yep, Vicodin. So it's Norco, Vicodin, and Lortab. And they're the same medication. The only thing that's different in Norco, Vicodin, and Lortab is the amount of the narcotic that's in it. So Norco is 5 milligrams of narcotic and 500 milligrams of Tylenol. Okay? Vicodin is 10 milligrams of narcotic and 500 milligrams of Tylenol. Lortab is 15 to 500. So it's just the different dosages of the narcotic that's in it, but it's the same narcotic that's in all three of those. So if I was giving my patient Vicodin around the clock, they would be getting, because you usually give 2 at a time, that's 1,000 milligrams of Tylenol every time they take it. And so you got to be careful about that. And you probably want to choose a different type of pain medication for your patient. Take a break. I did not realize how late it was. Please take a break. You guys just let me talk. I know I did not say. Sorry.
Hey, Jody, come here.